Hello, my name is Michelle Morand. I am a precision cancer medicine educator and advocate, and I'm here today with the cancer guy, Alexander Rolland, precision cancer medicine specialist, and he's prepared a little presentation for you about late-stage cervical cancer and a really exciting new treatment option. Just one of many, but we're going to talk about just one today. Hello, Alex.
Hello. I'd just like to add it's the new improved cancer guy. I got a haircut.
Okay, great. You got a few hairs cut, as they say.
Yes.
Mhm.
Yeah, this is just another piece of excitement on the antibody drug conjugate buzz. We're seeing a lot of these being approved in late stage, heavily pretreated, which is great because, really that kind of area has been dominated by intravenous chemo, which is really hard to tolerate at that stage.
Yeah.
And so having these options is good. What we're going to see, obviously, is we're going to see these drugs that are so effective at late stages being used at much earlier stages in an effort to prolong the cancer-free period of time. And I expect we're going to see a lot of that. So this new drug, antibody drug conjugate, we'll go over that in a second. This targets something called the tissue factor, and it's just recently been FDA approved. So tissue factor is normally involved in enable cells to initiate blood coagulation of all things, but it is also highly expressed in cervical and other cancers. So once again, antibody drug conjugates are an exciting new technology composed of an antibody that is attached to a very small amount of chemo drug. And when the antibody attaches to the receptor on the outside of the tumor cell, in this case, the tissue factor, the cell takes in the antibody drug conjugate and a small amount of chemo is released, killing the cell from the inside out. Now, you did ask a question earlier about how much chemo is attached to an antibody drug conjugate.
I did.
And I think it varies depending on the chemo drug, which is another exciting thing, is that we're finding that there's many different companies now building antibody drug conjugates against the same target, but they use different drugs. And what is really exciting about that
Hmm.
is that you can actually use these different drugs to target the same molecular feature. So, for example, if you use a drug that targets a tissue factor and it stops working, then you can try a different company's drug because it's going to use a different chemotherapy and at a different concentration.
Hmm. So these could be used like sequentially to get
Yeah.
full greater benefit.
We're we're actually seeing that with a variety of different drugs, including the
Wow.
HER2 inhibitors and the different antibodies. Is you actually can use them sequentially. You can use one company's drug and then another company's drug and another company's drug.
And that just keeps those particular mutations at bay.
Well, it still targets the same receptor, but what it does is, some cancer cells are going to be resistant to certain types of chemo.
Yeah.
And so, then what you could do then is you can optimize the particular brand of antibody drug conjugate to a chemo drug that is going to be more effective in you.
Right. So is there a test right now in the way that we
Yeah.
have like an
Yeah,
oncotype?
so with the tumor DNA sequencing that we do and the tumor RNA expression testing,
Yeah.
we can tell which chemotherapy drugs will be effective and which chemotherapy drugs will not be effective for a person.
Okay. So we'll
Yeah,
come back to talk about
normally do
testing a little
that.
bit
We
later.
normally do that. We'll normally say, oh, this chemo is not going to be effective. This one will be. We normally do that in our reports,
Okay.
but with the antibody drug conjugates, that just allows us to really define
Yeah.
who gets what.
So that's even more
Personalized.
accuracy in your
Yes.
treatment. So it's targeting. So folks, just so it's clear, these particular types of drugs, instead of the chemo, which is systemic, it goes through your whole body, targets all rapidly reproducing cells. These particular drugs they're attached to this antibody designed to find specific mutations. Is that, yeah, they're looking for a
Yes.
specific
Yes.
mutation. And
Yes.
then when they find that cell that has that specific mutation, they deliver the chemotherapy into the cell. So far more accurate delivery to the part of the body that needs it, and far smaller amount of chemotherapy required.
Yes, exactly. And that's another great point. The problem with chemotherapy, one of the problems, is it's largely based on what we call, the dosing is largely based on EGFR, estimated glomerular filtration rate, which is basically it's a marker, a blood test that looks at how well our kidneys are excreting a molecule called creatinine.
Okay.
And when our kidneys excrete this molecule, they do it at a very predictable rate. We have typically a predictable amount of this molecule in our bodies, although that changes depending on if you're taking creatine supplements or if you're an athlete, because it's this molecule is produced by muscle usage. And so what happens is doctors will basically look at this and say, okay, yes, we can give you more of the drug or less of the drug, and because of that, and because this is not a reliable source of kidney function until the kidney's completely damaged, we end up dosing 1/3 of the populations with too high of a level of chemo, the other third with not enough chemo, and we get it right about 1/3 of the time.
Mm-hmm.
So this is a great solution to fix this problem. Rather than soaking the entire body with a chemotherapy drug in hopes that it will find a tumor, much better to target it with an antibody and use a minimal amount, just enough to kill the tumors.
Right. Yeah.
So in this particular case, as you can see up here, this is a drug, tisotumab, and MAB at the end of any chemical name or drug name means monoclonal antibody. So tisotumab is the antibody that binds onto this receptor here called the tissue factor. So the antibody has this classic Y shape that you'll see all antibodies are kind of given that shape in science. And these little red dots here, or these little red stars here, are the particular type of chemo drug. In this particular case, the chemo drug is called MMAE. And then this is the linker that attaches the two together. So this is a tumor cell, binds onto the receptor, gets taken in. The drug gets cleaved from the receptor, gets released, and basically it kills the cancer from the inside out. And this hopefully would answer your question, how much chemo is on an actual antibody drug conjugate. There's antibody drug conjugates with what they call bystander effect, and then there's ones without bystander effect. Now, it's a bit of a more complicated process, but bystander effect means that once it kills that one cell, there's enough of the chemotherapy agents to actually kill the neighboring cells as well. And that's important because not every cell in the tumor may have this tissue factor for the antibody tisotumab to bind to. So if you have a clump of tumors and let's say 70% have the tissue factor, then tisotumab will bind that 70% or 60%. It's probably more realistic. And then it will release it into those cells. And then those cells will then release a chemo drug and it will kill the surrounding tumor cells that don't have the tissue factor antibody. So bystander effect is a good thing to have for a antibody drug conjugate. And it typically means that there's more of the drug to kill multiple cells rather than just the one tumor cell.
Okay.
Does that answer your question?
Yes, thank you. I'm sure I'll have more, but that's good.
This trial enrolled 502 patients with recurrent or metastatic cervical cancer who'd received one or two prior systemic therapies, including chemotherapy with or without bevacizumab, which is also an antibody known as Avastin against angiogenesis, and or a anti-PD-1 inhibitor, so that's immune therapy. So patients received either tisotumab vedotin intravenously or investigators' choice of standard chemotherapy drugs consisting of topotecan, vinorelbine, gemcitabine, irinotecan, or pemetrexed. Just a little explanation of statistics. It's really important if you're a cancer patient or caregiver of a cancer patient that you understand the statistics commonly used in cancer. We have what's called the ORR, or overall response rate. That refers to how many patients out of 100 in a trial respond to the drug. Now, the responses are broken down into 3 positive responses, 1 negative response. That is a complete response, partial response, stable disease, and then we have progressive disease, which is a negative response. Progressive disease means that the patients didn't respond to the drug positively, the tumors grew. And then we have the PFS, which is progression-free survival. This is a period of time in a trial that starts when patients take the drug and stops when 50% of those patients relapse. And this is what we call a median. So progression-free survival, PFS, and overall survival, OS, are both medians. And that's important to know. It's not everyone in the trial. It's only 50% of the patients have had a relapse. So the other 50% may not have had a relapse, but for progression-free survival, it's been 50%. And this is important because, doctors want to be able to tell a patient, well, we know you have at least a 50% chance of achieving this time period cancer-free. And so the same statistic is used for overall survival, except death is used instead of progression. And so this refers to the time in the trial where 50% of the patients on a drug die from the disease. And it's from the disease, it's not from other causes of death. So in this particular study, the overall response rate was 17.8%. Now, there's a bit of a range on that. It was 13.3 versus 23%. That's a pretty good response rate, almost one up to one quarter of patients. And when you compare that to only 5.2% for the chemo drugs, you can see that that's a fairly substantial difference. The progression-free survival was 4.2 months in the tisotumab vedotin arm versus 2.9 months for those treated with chemotherapy. Now, once again, there's a bit of a range there. And the overall survival was 11.5 months with a range of up to 14.9 months in the tisotumab vedotin arm versus only 9.5 months in the chemotherapy arm. Most common adverse events, which are side effects, occurred in a little more than 25% of patients, included laboratory abnormalities. In other words, things that are flagged on a blood test, decreased hemoglobin, which is a molecule that helps us transport oxygen and carbon dioxide throughout the body on red blood cells. Peripheral neuropathy. Peripheral neuropathy is when the chemotherapy agents pool up in the fingertips and the toes, and that is avoidable with cold packs or Voltaren. You can really reduce it significantly by using cold packs. And then there's conjunctival adverse reactions, increased aspartate aminotransferase, nausea, increased alanine aminotransferase, fatigue, decreased sodium, nosebleeds, and some constipation. So slightly different types of side effects from what you would expect within chemo.
Okay.
And in chemo, just an example of a drug, topotecan, you can see right there's quite a few different, fairly significant side effects: body aches, pains, chest pain, congestion, cough, difficulty of labored breathing, dryness, soreness of the throat. It goes on and on and on. So the side effects from these antibody drug conjugates are a fraction of what occurs with systemic chemo.
Yeah. And again, largely that's because you're having such a smaller amount of the drug.
Yeah.
It's so targeted to the cells that need the treatment, for sure.
And then once again, this is just one of the many thousands of antibody drug conjugates in development right now. Last time I checked for HER2, there was 1,500 different companies making HER2 antibody drug conjugates.
Wow. Wow.
And there's about 4 approved. And what's really exciting is the companies are using different antibodies. They're not just using Herceptin or pertuzumab. They're actually finding different areas of the receptor to bind to. And so that's another exciting area of development in antibody drug conjugates. So antibody drug conjugates have 3 major components. They have the antibody that binds the receptor, and they can, improve on that by using multiple antibodies to bind a receptor, or, binding of mutated receptors. There's a whole technology there. And there's a conjugate technology. And so the conjugate technology tells us when to release the drug. And so in early antibody drug conjugates, they didn't have the conjugate technology fully stratified. And sometimes they would develop these antibody drug conjugates that would release their chemotherapy cargo in the blood, or, too early before it reached the tumor. Not enough of it was reaching the tumor. But now that they've really perfected the conjugate side of things, they're able to tailor these specific conjugates to release the drug only at specific places, such as the tumor. But more importantly, they're going to be able to adapt that and really focus it on specific mutations or specific features of the cell.
Mm-hmm.
And then, of course, having the ability to use multiple different chemotherapy drugs for the same target really opens up the treatment potential.
Mm-hmm. So we've got the potential for, as you were just saying, the potential for multiple antibodies.
Yeah, like you can have two antibodies. So there's actually an antibody drug conjugate now that targets two different components of the HER2 receptor. So if the HER2 receptor is, and this is the domain 2 and domain 4, I believe. And so if you're missing a domain 2 on your HER2 receptor, which can happen in cancer, then the other antibody will bind the domain 4 and make sure that that cell gets killed. So
Backup upon
it just
backup.
improves the efficiency of it.
Mm-hmm. Yeah. And as you were saying earlier, if they're making a bunch, so there's all these different options and possible permutations, and then there's the same antibody but different type of chemotherapy.
Yeah, yeah.
So
Or radioactive isotope,
right. Yes.
or as in theranostics for prostate cancers, and lutetium-177. Or now they're actually coming up with a really exciting technology called BiTEs, bispecific T-cell engagers, where you have the antibody component attaching the tumor cell directly to a cytotoxic T cell that's going to kill it,
Mm.
like
Mm.
a dating service.
Right. Yeah, like like
A
velvet.
bad dating service.
Like there's like those little things in the garden that kind of stick to your socks as you walk by, like
Yeah,
there's no getting
exactly.
away from them. So folks, oh, I'll let you finish, Alex, and then I'll recap.
Yeah, so I just wanted to say how would you find out if any of these antibody drug conjugates would benefit you? Typically, what they do for clinical trials for antibody conjugates, and this will change, is they'll take your tumor sample and then they'll use a immunohistochemistry against that particular cell surface receptor. And basically, that's just a stain with the antibody in it, and so they can get a visual and count how many of those particular receptors are present, and then come up with a cutoff and say, well, you're supposed to have 70 of these receptors per cell, and we counted 90, so that means you have overexpression, or you have more of that receptor, so the drug should work. However, the number one, that uses up your tumor sample.
Right.
Number two,
So that's
IHC
just
is
one
not IHC is not the most accurate form
thing.
of testing. And number three, you can only do one antibody drug conjugate at a time.
Mm-hmm.
We have a solution for that. We use RNA expression testing. We have a 21,000 gene panel. It's actually slightly under 21,000. It's 20,800 or something like that. But it looks at just about every cell surface receptor that we know of. And so this will be able to predict if just about any of the antibody drug conjugates that are available now, or any in the future, will be of use to a person in one single test.
Mm-hmm. Yeah.
Not using up all of the tumor cell.
Just to check for one antibody as opposed to 20,800 or so.
Yes.
Yeah.
Yes.
Yeah. So that's a good point too about oftentimes folks will call us and they will want us to do testing for them, but their tumor biopsy has already been used for testing for to test one of these things, or there's lots of reasons for that in terms of how standard pathology is done and why it uses so much tissue versus precision cancer medicine sample preparation. But the point is, if you haven't done any testing yet, get your doctor to pause, make sure you use a test like this. It's a large panel, kind of like the only one you'd need, as opposed to wasting your tissue and then having to. There's a lot of misinformation out there about genetic testing, what it is, how it works, whether it's been done for you. A lot of doctors don't even understand this information. So that leads me to my next little point here, which is getting your oncologist on board. Being a well-educated and good self-advocate is a critical piece there. And that's what you can do if you join this link here. It's a little free program that I've created to help make sure that you are well educated about precision cancer medicine, about your cancer specifically, and all your treatment options, and that you know how to speak to your doctor to help them understand this and get them on board as well. But yeah, testing is the key. And I wanted to actually come back, Alex, to what you were saying about those statistics. So there's a statistic there you shared earlier, the overall response rate, 17.8% versus 5.2%.
Mhm.
Again, there was a range there, but still, obviously, the ADC is preferable. I guess what I wanted to say is, we've done some takedown videos of the analysis that certain doctors have done of certain studies, and it's important. Look at the study. I think you've linked it. Have you, Alex, or do I need to add it?
Yes, I think I did. Did I?
It will be
I put the
linked.
reference, I
You've
believe.
put the reference there. So whenever anybody is sharing information that is life or death and is about your cancer care with you, they should provide you a reference, and you should understand how to make sense of that reference. Does it, like, how do I know whether the side effects are more or less? Doctors will frequently, and I think just because they're not that well informed about these types of therapy, but they will frequently tell their patients, oh no, that has a lot more side effects. And right there in the study, like we've just shown you, you can see the difference in the types of things you might experience and how many of them there are. So when you're well educated about what's right for you and why it's right for you and how much it's really going to benefit you, it's much easier for you to successfully advocate to get a prescription that your doctor wouldn't otherwise perhaps offer you. And that's, of course, my passion here. Alex is all about the science and making sure that you're getting the right diagnostics and that you know which treatments are going to benefit you. And then my job is helping make that happen for you. So here you see, you can have a one-on-one consultation with Alex. He'll review your medical records and draft a report that you can share with your doctor with references. You can join the online self-advocacy training program. That's free. We have weekly meetings with me for advocacy training. And then once a month, Alex hops on and answers your very specific questions. And of course, visit our YouTube channel at The Cancer Guy and stay connected and stay informed.